of enforcing and managing a new ICU concept by Dr. Jozef Kesecioglu.
Let me, oh my God, this is my other presentation. So we'll do, no, yes. Okay, this is my old presentation I had sent last Tuesday, but I had given one now, but we will do with the old one. Doesn't matter, there are only very minor differences. So, some 13 years ago, we were asked by Board of Directors to do 2 changes in our hospital, because there were good reasons for that. And one of them was the changing of the organization, and the other one was to build up a state-of-the-art ICU, because everything was getting older, the concepts were getting older. And at that time, if you look at the first issue, the changing of the organization, there were quite a lot of things to do. Because we had actually in the hospital 4 different ICUs. And these 4 different ICUs were belonging to 4 different departments, such as surgery, internal medicine, anesthesiology, and the thorax surgery. What you saw there was actually, there were 4 different workflow for the nurses and the physicians. There were 4 different logistics. If you were keeping medicine A in this place, in the other ICU it was in completely different place. So it was really 4 different ICU. There were specialists working there, so there was extremely good care for the organs, like the cardiothoracic surgery or cardiology ICU. They had great knowledge of the heart. But they had a little bit less affinity outside their expert area, like antibiotics. Maybe the internal ICU knew better, but not the cardiothoracic ICU. CVVH, feeding, assist devices, etc. They were all localized to certain ICUs. It was even so far that the treatment of the same pathology was done differently in 4 different ICUs. I remember for ventilatory-associated pneumonia, one ICU was using amoxicillin, the other one was using ceftriaxone, the other one was using tazocin, etc. This was going on like that. And what we also have seen at that time, that there was no clear place of the ICU in the organization. ICU was not a department. ICU was a working place belonging to the department. There were no medical responsibility, no clear medical responsibility. Who was the head of the department? No, there were no heads of the departments. There were some heroes, because they were the people who were either from character a bit dominant, or they were specialized on certain treatments. So if in the middle of the night something happened, the common thing would be, yeah, let's keep the patient like this. He will come or she will come tomorrow morning, and things will be getting better. There was also no clear nursing responsibility. And due to the facts that I just mentioned a few minutes ago about the logistics being different, and of course the 4 ICUs were having different patient categories, there was absolutely no possibility of exchanging the personnel with each other, because they wouldn't be able to take care of the patients of the other discipline. There was a great stagnation of the OR program, because, for example, the cardiothoracic ICU would be totally full, but an internal medicine ICU would not be able to take care of these patients. Now we also, I must admit, have some OR program problems, but that's totally due to different reasons, but it's not comparable with the old days. There was stagnation in acute admissions, and as I said, one ICU could be full, while the other one would have a few beds, but nobody were able. The intention was there, but nobody were able to help to each other. So we had also complete different cultures and rules and regulations. The visiting hours of the 4 ICUs were different. Attitudes towards the family members were different. The materials and medical devices were completely different in 4 ICUs. When we took over, we have counted that there were 9 mechanical ventilator types in one organization. So, in summary, the ICU was in fragmented departments, but not an institution by itself. So the aim was make ICU one organization. This was the message that we have got from the board of directors. And then let's see what we got in 10 years of time. When we were starting with this, there were, of course, a lot of challenges. And the challenges were rising from the insecurity of the people, because people had worked many years with a certain methodology, and they were insecure whether whether the chosen system for the future, what we thought was being rather innovative, whether it would be really working or whether they would be able to cope with it. And they had also uncertainty. The uncertainty was also coming from the fear that they had, feeling themselves whether they were competent enough or not. And this has also translated itself to a certain sort of aggression. We don't want to do this. And it took us a lot of energy to prepare people for the great change. And when we started the change, we of course started with the education. And at this phase, it is very important to let the people be able to talk and explain what they need. Because it is very difficult for us to know what somebody needs in order to increase his or her knowledge. The only possible way is he or she tells it where the weakness is, but you have to give a little bit of trust to these people so that they can express that. There were a lot of trainings being performed, and there were standard workflow procedures, material and equipment were determined. And you see the standard of care was determined, either for the nurse or for the physician. One protocol, one way of guidelines, one system of antibiotics, whatever. And you see here an example of our document. This was a pocket document, and it was called the harmonization of the ICU. Actually, we started from A to Z, and there we determined the working hours, standard for the whole ICU, the materials to be used, and etc., etc. This was a huge work which took about a total of about 7 years, but the first 2 or 3 years were rather quite powerful years. So we also had a lot of disagreement, the nurses among each other, the nurses with the physicians among each other, and the only thing that we were coming back to was what do the patient and the family members need? Because if we have seen that if you bring the discussion to that point, actually the professionalism prevails and the personal feelings a little bit go down, but you have to bring the people to that point. You have to put the patient in front of them so that they realize that if we do this, this is better for the patient. So we have also produced some statements. We said that the structured organization saved the lives of the patients. Believe me, after the new organization started with one multidisciplinary ICU, at the end of the year, mortality was slightly lowered. We also said each bed should be available for any patient independent of the initial diagnosis, which would provide flexibility, efficiency, but also enough knowledge and expertise for each physician and nurse to take care of the patient as an individual and not as an organ. And that brought us to the last point of treating the patients and not treating their organs. So what we have achieved in 2017, we have a multidisciplinary ICU. Any patient can be put any available bed at that moment without the underlying pathology. We almost reject no acute patients. In the whole 2,300 admissions of last year, with 100 patients admitted and stabilized and transferred to another unit. There were only 5 patients who really could not come to the ICU and were stabilized in the emergency department. So this was a huge decrease, because in the past it was 20-fold more than what I'm now mentioning. So the efficient use of beds, that was, and finally the most important thing is that the great change of culture in the physician and nurse teams. That does not mean that we have reached to the end, because interestingly, a couple of days ago, we have started a new project in order to increase the interaction between the nurses and the physicians, directed to the better patient care. But if you compare it as with 10 years ago, actually 13 years ago, you will see that the nurses among each other, the physicians definitely among each other, but also physician-nurse interaction is more teamwork than in the past. And what I always remember very well from the past was that from the nursing part or from the physician's part, we of course had always a lot of problems in the transition period, and mostly the attitude was to come into my room and say, this is the problem and we want a solution, and leaving. What now happens mostly is that my colleagues come in and they say, we have this problem and we think that we have to solve it like this and this and that. So this, I think, was quite an achievement. So we, after starting this whole project, a couple of years later, somewhere in 2006, we were getting the message that we should build up a new ICU. And then we said, let's build up a new ICU, but how are we going to do this? Because, I mean, the classical way of 4 walls with 1 ceiling and 1 floor, and then put some beds in it, and what mechanical ventilation Joseph likes or Arjen likes, and let's buy that and then see what happens afterwards. We did not want it. We said we have to define a vision and create the best atmosphere for the patients and the family members. However, we had a problem there, because we had a team. Actually, the team was as big as 70 people, some people having a more prominent role than the others. We had several groups, but in the top of the group, a few people, we just sat down and started to speculate what would a patient actually need and what would a family member would actually need. I was very impressed this morning, actually, when we had these 2 patients, one of them being our colleague, telling their experiences, because at a certain moment we couldn't go further than speculation, because none of us had been a patient in ICU and none of our family members had been patients in ICU. So we started to call back the patients. I didn't do the interview myself. There were a lot of nurses, quality people who are working on that, and the patients were called back, they were interviewed. Family members were called back, also from the patients who had not survived, and we asked them a lot of questions. And we got a lot of feedback. I will show you actually what the feedback were. We documented that. We have recategorized that, stratified it, and then we just went back to the work. And what we did was also to create a mock-up room to test the functioning of the new ideas and visions. So what we got was the patient-centered care, which dictated the architecture. The building is made completely from the perspective of the patient and the family, and we added that the functionality and the safety. So if we look at the patient part of it, it was for us clear. For many people it was for many years ago clear, but for us at that time it was not clear, and a lot of people disliked this. But from the ward system, we said we are going to switch back to the private room system. This has, if you look at it now, certainly created a huge amount of privacy. The noise almost is non-existent compared with the ward nursing. The decrease of infection, we were seeing it from theoretical grounds, but that is quite difficult to show it in the Netherlands setting, because as Hans has mentioned in his talk half an hour ago, Dutch centers usually use selective digestive tract decontamination, and we have much lower rate of infections, but we certainly reduced the medication errors with also the participation of the pharmacy, which I will show some minutes later. And what you also see is that the communication is improved, the patient-family interaction is much better at this moment, because the family members can speak with their patient things that they probably did not dare to speak in a ward, because everybody would be listening them and hearing them. And also the nurse-family interaction and nurse-patient interaction is more private among each other. We said the patient would need definitely natural light, because that was also one of the complaints, and that's also very logical, I think, because one of our 4 ICUs were already in the basement of the hospital, and this was ironically the internal medicine ICU where the longest stay of the patients were observed, and we gave them day and night rhythm, although we gave them the day and night rhythm, although we have also heard this morning that there are moments of the period that it has a different perception than at that time we thought that it would have. We have seen actually in the literature that daylight reduced agitation and decreased the length of stay, and we have seen in the literature that decreased the pain medication, although it is difficult to get behind it what the relation with these things would be, and certainly reduce depression instead of looking at the darkness. Well, I was very much touched actually, because I heard when in the morning that the patient looked at the clock and he could not interpret it at the moment of the confusion, because theoretically we thought the patient should have a clock so that they can look at it and they can differentiate the day and the night and the time of the day and so forth. But as you see in the reality, it's not always the case, but I'm sure we have still a lot of patients who are profiting from that. We have an armchair like you would have in your home, a red lamp like this. I mean, I was teasing this a lot when it was planned, but if you go now around 5 o'clock or 6 o'clock in the afternoon, you see everybody is putting it on, and the patients, family members, nurses, they are all very happy. We put a whiteboard here where the nurse every day writes the date and her name, and the physician writes the number of his telephone so that the patient knows who cares, him or her, and the family knows that, and the nurse can call the doctor anytime it's necessary. And we used soft colors and very flat surfaces without any holes or motifs or designs or whatever. It's very smooth color. Then we had for certain things for the family, and you see that family actually needs certain things, and they got a PC with internet. I mean, you would say that everybody now has a telephone, they can do everything with it, yet you see that these computers are regularly used. A TV, telephone, meeting space, a cafeteria, and we will see now what was the effect of these things on the family members. The patient room numbers, we were told by colleagues in other ICUs that in a very busy ICU, if you would just abruptly walk in and ask the nurse what is the number of the room, it was possible that he or she would not be able to say it. So we put a big number there. The signage and wayfinding techniques were optimized, and it nowadays works very well, and we needed that as well, because the ICU is so symmetric that if you are coming out of a room, you may not know where you are if you don't follow the signage very well. one of the biggest achievements I think I may dare to say is the 24-hour visiting policy of the patients. It was a big resistance from the nursing personnel because they said we will never be able to get rid of the patients. If they come once, they will stay 24 hours. We said we will talk to them because the aim is not staying 24 hours. The aim is to be able to visit when you want. We have seen a huge difference with the old situation. I mean, if you don't hear a complaint anymore, it means that it's successful. Nobody is going to make a compliment. Don't wait for that. But if you don't hear the complaint, then it's okay. So what we don't hear anymore is that there are too many family members, because when the day is 24 hours, it's better than the day of 3 hours. Because if you say you are going to visit the patient between 3 and 6 o'clock, then you have about 30 patients there. There will be at least 90 family members walking between those hours. While now it is evenly distributed. I'm not saying evenly distributed to 24 hours, because our family members are very wise. They don't come at 6 o'clock in the morning or 3 o'clock at night, but it is evenly spread to the whole day, and everybody can come whenever it fits them. But we also have people who need to come at night because the patient is very ill. They are very welcome. Nobody kicks them out. For very ill patients, we have 6 bedrooms. Sorry, for very ill patients, we have 36 bedrooms. But for the families of the very ill patients, we have 6 bedrooms, which they can use for a couple of days until the patient is stabilized, or maybe unfortunately not. This is the study that we have performed a couple of years ago. You see the before and after period. In nurse-patient ratio or patient population being mixed ICU, there are no differences. There are only the differences are in the space that we have provided for the new ICU, the noise which was reduced significantly, and the workflow which was significantly different. What you see here is that if you look at the family, the total satisfaction was significantly higher with the new situation, especially on the subscale satisfaction with care. And if you focus on certain items, the family members were especially very satisfied due to the atmosphere of ICU, the visiting possibilities, the atmosphere of the waiting room, the facilities of the waiting room. There were some drinks, soft drinks, and the coffee, tea possibility, and some sandwiches. The emotional support, I mean, this is quite interesting, and we don't know where it is coming from. Because apparently the family felt in the new situation that they were having more emotional support. Apparently courtesy towards the family by the physicians and nurses were also increasing. And apparently the environment has also made positive effects on the medical and the nursing people. They were all in favor of the new ICU. And you see here ICU environment being the determinant factor in satisfaction. The patients were also similar in subscale satisfaction with care and total satisfaction. They were much more satisfied in the new environment. And again, the almost same issues were coming back. The courtesy, the atmosphere of ICU, the silence, the visiting possibilities were scoring as factors which were highly improved. And again, this I said at the beginning, we have read the literature that in better environment, the pain was reduced. And I don't know what the mechanism is. I am very anxious to hear from you if anybody can explain that. But this we have seen also in our patients. The pain management was improving with the environment. They found the stuff more recognizable because we have a different working system. You will see it in the slides following. The nurses and the physicians are all around the rooms. They don't go to a certain room and get themselves closed in and start to work there, but the physicians see the patient and they go out of the room. Right in front of the room we have working terminals, and we sit down, trainee specialist, nurse, sometimes specialists from other departments, and we determine the next 24 hours of the patient right in front of the rooms. So again, the ICU environment scored here as a determinant factor of satisfaction. So if I go further with the ICU a little bit over the functionality and safety, we have defined actually three factors here. The first one is what exactly I was mentioning a couple of seconds before, physicians and nurse at bedside or nearby. The second one was on ergonomics, and the third one was on safety. And you see that we have sort of racetrack configuration, that the rooms are next to each other, and they also look towards each other. And at a certain moment, you cannot see the patient from a central post. And this was very good because in the old system, everybody was gathering behind the central post. Now, and they were talking loudly. And now the care is decentralized. They are spread all evenly, the personnel on the working floor. And you see, this is the typical way of, I mean, here the monitor is not installed and they are already changed with the new versions. Don't worry, they are not falling down. So we have the workstations and between the two rooms, and with these PCs, you can almost do everything that you can do inside. Also, you can do it outside. And the selection of the equipment, what we did here, actually, we looked at what our patients needed. We didn't look which monitor is better than the other, because if you look at the market, there are a couple of monitors which are not exactly the same as each other, but they are all high quality. And we were doing the selection about 9 years ago. We asked for a monitor where you could change the alarms and all the installations from outside the room in order to avoid that every time nurse goes in the room, when the patient is sleeping at least. So this was something that was defined before choosing the brand. And it went on and on like this. And this was the final point, actually, or actually the beginning point. Select the equipment that fits to the concepts developed and not develop concepts after selection of the equipment. This was, I think, one of our strong points. Of course, we had seating service units in order to have all the equipment off the floor as much as it can be, because there are, of course, occasional CVVH and left ventricular assist devices. They are not always in the room. They are on the floor. And for the safety, the patient alarms are still developing. That's a totally different subject. I will not spend time on that. But we are finally reaching to a point that we can minimize our alarms, at least in the most primitive settings, and it will develop to be much better. But the logistics and pharmacy were two important factors here. First of all, the most important thing is that the nurses don't have to get out of the room every time to pick up something, because 24 hours supplies are brought to them. And you see here the drawers. There are in total, as of today, because the logistics have changed according to the measurements we made, there are 10 drawers which are brought to the room of the patient every single day. And two of them are, one of them is the medication, so 9 of the drawers are changed every day, irrespective of the room being used or not, because it's not the duty of the logistic personnel to check if the drawers are used. They change it and they do the check in a different location. And the nurses, the calculated availability of the daily required material is 95% here. And for the 5%, they have to walk to the central storage place. The same thing is true for the medication. We have a satellite pharmacy within the ICU, and it's the complete territory of the pharmacist. We don't bother there. And there are syringes being prepared and put in a refrigerator close to the unit. The nurses can take it by barcoding, and also the medicine which does not need refrigeration is brought to the units at around 2 o'clock every afternoon, and that is for the next 24 hours. And we have by doing this, we have reduced the work of the nurse 80%. 20% of the work is still done by the nurse because the pharmacy is not 24/7, but they work between 8 o'clock and 5 o'clock in the afternoon. So we also had another study performed on the course of delirium. This was the study of Aryan. We have also looked at the old building and later done the measurements in the new building. Very shortly, I will just I just show these first two rows. We have seen actually that the incidence of delirium did not change. It was exactly the same as in the old atmosphere. However, the duration of the delirium was shorter in the new situation. A point for discussion, I presume. So I would like to conclude that the organization's structured on the needs of patient and family is mandatory. The concepts should be developed leading to architecture and medical equipments. Materials, apparatus, and building can get outdated, but concepts like daylight, quiet surrounding, privacy, ergonomic safety will be the future. Now, everybody thought that I would finish here, but there was a little trick here, because there was a little trick. Those who were really observing the program and my title have seen that I have taken a part of the title away and I put it back again here, because the title actually started, what's the personal price for innovation? Now, the personal price, can you interpret it in many ways? I mean, there are a lot of personal prices. You can give many, many answers, or you can choose to give no answer at all. I mean, that's also an answer. I just put there a few things, but personal price, I have taken it very personally. That's why I will only tell things which I think that they are good or maybe not good. So the positive things were that the survival has increased in the years, although we still have a lot of work to do and we have a completely different case mix than the rest of the country. We are doing well. We have satisfaction of the patients and the family. We have satisfaction of the nursing and medical personnel, although problems never cease. You have to always go to one step further and further. It's a unique concept because it becomes old and old, but as of last week, I still had some visitors after 7 years of opening visiting the ICU. So it is nice. And it's an award-winning ICU. We have one, it's very badly seen there, but the Society of the Critical Care Medicine, the American Association of Critical Care Nurses, and American Institute of Architects Academy on Architecture for Health give the Best Design ICU award every year. And we were actually, if I followed the last 2 years also correctly, we are actually the only ICU outside of North America who got this award. And these are the positive things. I like them. The negative things is that we realize that in order to lead such a project, you need a coronary artery, something like 14 or 16 of them, and each one of them have to be this thick. So far it proved to be like that. I don't know what happens. You have a lot of broken hearts, especially at the beginning of the changes, because people don't like to change, and you have to convince them. Some of them say, I don't want this, and go away, and some of them stay and follow it. But the good thing is that if you would walk around today and ask everybody who wants to go to the old ICU with the old system, there won't be more than maybe 3 or 4 people. And of course, you have all this period of unrest, worries, fear, and aggression. And finally, you become actually the symbol of the reorganization. But for the rest, I mean, if you ask me if I would do this again, I would say no. At the age of 60, I won't do it again. But if I could be back 10 years or 15 years, I would do this exactly the same the way that I wanted to do. I did it. Thank you very much.
Joseph, thanks so much for this talk. Are there any questions? I think I really like your logistics. It's great. So, there's one. Okay.
What was the price of this unit? I mean, how much more does it cost you than the old one did?
We had a budget. I mean, there was a calculation of budget before we started to make the plans. So the calculation was based completely on the functionality. And the Dutch necessities are quite high. You have to be obeying a lot of rules. So a normal ICU would be much cheaper somewhere else, but we had a budget of 25 million euros. We have ended up with 24.3 or 24.4. And then we had a bonus from board of directors. They said, are there things that you want to change now? Because you have saved so much money when doing this project. Then we said we want makeup. Because everybody looks around and say, what a beautiful ICU. For that beauty, I think it was, I can't remember exactly, but it was some 450,000 or something like that. They are all cheap materials, but they are nice. We had an internal architect who has changed the appearance of the ICU. So we stayed within the budget of 25 million.
So that was good planning. But how about the running costs?
Running costs in terms of? Because
I mean, in comparison to the old ward.
I don't think we have more expenses here because let me give a couple of examples. If you look at the satellite pharmacy, the satellite pharmacy costs money. But we have calculated the workload and we needed much less nurses because the nurses were not preparing 80% of the medication themselves. So there are a lot of tricks like this. And at the end of the day, to be more honest with you and not to defend for everything, because I don't have everything in my memory now, the point here is that in the Dutch system, or at least in our hospital system, we are paid by the length of stay per each day. So the income that we have is quite in equilibrium. So we are not each year 3-4 million negative.
Oh, wait. In the study that you showed us where the before and after with the new ICU, you had not decreased incidence of, or prevalence of delirium, but decreased days. What's your thought about the mechanism?
Well, I have a thought, but the real expert is there. I think in my thought, just for a simple intensivist who doesn't know too much about delirium, I mean, delirium has many etiology. And it's not the environment which only makes the people having delirium. The question here is actually why we couldn't decrease the, the question is not, in my opinion, why we couldn't decrease the incidence, but why we could decrease the duration. And there might be, I mean, the only difference I think we had was the environment, but I don't know whether you want to comment on that.
I agree with you. Well, from this study, it would suggest that mechanisms that are related to the duration of delirium are different from mechanisms related to the occurrence of delirium. But that is a bit speculation. It could also be a chance finding, I guess. Interesting was that there was an effect anyway with relatively small numbers supporting the non-pharmacological interventions, I think, and stressing that these are important.
You know, because one of the things I was thinking was that, you know, the patients come in, they're acutely ill, and that piece of the delirium, you can't impact that piece with the environment. But now if you have brighter rooms, you're mobilizing patients, you're decreasing, as Arjun says, you're decreasing the duration because you're impacting things like, you know, maintaining their sleep-wake or their circadian rhythm or other things. So, I mean, I actually find that very interesting.
So your new ICU is very, very impressive. And if I had a choice, in case I would get administered to the ICU, I would choose definitely yours instead of the old ward. Still, when looking at your numbers, I found that the absolute increase was not so impressive for several numbers. So for satisfaction, if I recall it right, for patients, already the base rate of satisfaction in the old ward was about 60, and then it was a 4-point absolute percentage increase, although it got significant. But still, it seemed the change to the better in absolute numbers is not so impressive. You got money from somewhere to build this new ICU, but still I would wonder In other ICUs, people would have to decide whether they would just refurnish or redo their ICUs to your new concept. It was really worth all the money for 4 or 5 percentage points, given that some of the base rate numbers were already pretty high.
Yeah. The point is that there is a power calculation made there, and it fulfilled the power calculation. So that's the case. I can't now. It was many years ago, so I can't remember now what was the expected the included amount of the patients and so forth. However, I must say that increase of satisfaction. Even if it is 5%, it is better than if it would not be 5%. So we can argue on that, but at the end, it is something which shows there the whole change of the, I mean, it's not only the satisfaction, but also the indirect change of the attitude of the personnel working there, which I find much more important than having this significant effect, whether it's 5 or 15 or 25. I think if we would reduce mortality 5%, we wouldn't be complaining too much about that. So that is one point. The second point is I can't convince you with this study perhaps, but the most important morning was the first morning after moving from the old ICU to the new one. And we have 3 units looking to east, south and west. And the nurses of the east and some of the patients even who were not intubated, they were looking at the sun rising. It was one of the few days that in Netherlands the sun rises, but everybody was starting with oh. This was something which was very special. I don't know. If you look at the numbers, you can say easily what you said. But on the other hand, there was, I mean, if we would build up this ICU in the basement of the hospital, we would pay 25 million. That's for sure.
I don't want to be misunderstood. It's not to talk it down. It's just when we have to make a decision between money and improvements in satisfaction or mortality or other things, where should be the balance, or what can we afford?
I know, but again, I will repeat it for a third time, but I won't say it once more. We really had to give this money. I mean, if you don't give this money, you don't get an ICU. We had the chance, we had the luck that we got permission to build the ICU on the top of the hospital so that we didn't have any obstructions, no columns, no things. But if we would build it anywhere else for the infrastructure, this 25 million was necessary.
Yeah, one question, apart from the fact that I believe this is one of the very important prototypical experiments for radical change in hospital design that I believe will be coming. And we have to also consider that the relationship between investment into technology and the building has a very significant difference, because we're exchanging technology every 3, 4, 5 years, but the building's there for 100 years. So we really need to understand that what we build today will be there in 100 years. So the relationship and the investment needs to be also considered. That's why I think it's a very important study. But my question is, if I understood correctly, then you went from 12 square meters per bed to 25, and you increased the number of beds. That means that you had to eat it up somewhere else. How did you do that, and how did the calculation work there? Because suddenly, of course, you have you're kind of doubling the investment for each bed.
Exactly. That's a very good question, because the beds at that moment went up to 36, and we even have 4 secret beds. Nobody knows where they are, but they are different rooms. We can even make it 40. But we have done that at that moment with the thought that maybe in the future we will need more beds. What we have now is, due to the multidisciplinary character of the ICU, that everybody can stay anywhere that you can put it, actually our beds available are very flexible. It can be such that during the week we have 31 beds open. In the weekend we will definitely have 5 or 6 beds less. In vacation period we would reduce it to 24. At a certain moment there will be 2 acute patients. We will try to get nurses in to open the beds, and at a certain moment we will have 5 beds empty. We will reduce it maybe to 2 beds empty, and we will ask the nurses whether there is somebody who wants to go home. And at the end of the year, when you look at the average from 32 or 31, 32 we never had it. 32 was the physical availability, but we had 31 beds available. It is now at year basis reduced to 26.7. So actually this did not cause us to expand more, but there were 2 effects. First, the operational beds are now much lower, so again the costs could be there contained. But the second thing is that when we had exactly the amount of the beds as we could get the patients in, when we didn't have a bed, then nobody could get in. Or if we couldn't get the patient out yet because the patient would be going to the ward at 2 o'clock, then we couldn't get a new one. Not because we didn't want to, but there was no physical availability. Now we just get the patient as an extra bed before the other goes, and the other one goes 2 hours later. So it gives us a lot of flexibility.
Thank you very much for the talk. I appreciate it very much, and I think it's a good plan for the future if somebody wants to rebuild his ICUs. Yet I have a question. In one of the tables, you described the ratio between nurses to patient over 24 hours as 4.4 to 1. This was on one of the tables, which would be roughly double that what we got in Germany.
That's per bed.
One?
Per bed. The FTE.
Yes, per bed. I mean, normally 1 patient in a bed.
Total number of FTE, the total number of nurses we need to operate the ICU is 4 point something per bed.
So, no, they're working in a shift. So usually you need 5 nurses to have 1 shift done. So
I know.
That's why.
But still, if you translate this to a 24-hour shift as compared to Germany, this is roughly double the number of nurses as we got in Germany. Yes, definitely.
Yes, it is.
Definitely.
I mean, during the day we have mostly one-to-one care.
We have during the day at best 1 to 2.
Okay, we have that at night.
Right. We have it 1 to 2 at best. And so my question then would be, could you run this ICU with half the staff of nurses?
I don't think so, no.
So,
no, but do we advocate that 1 to 2 is better than 1 to 1? I mean, I'm envying Hans because he has 1 to 1, I think 24 hours.
No, he means a nurse has to take care of 2 patients. And this is usually not in your case. You have 1 nurse.
Right, and the question and the point I want to make is that you describe the model, the relatives can come whenever they want.
Yeah.
I mean, this is great. The prerequisite, however, is that there is some nurse staff taking them by hand, bringing them in, explaining. And with half the nurse staffing, things get really troublesome.
I agree.
And impossible sometimes. Yeah. And this is a problem we got in Germany. Yeah. Even though we would like to pay for nurses, we don't get them anymore.
Yeah, I agree with you because we have exactly the same problem because nobody wants to be massively choosing the nursing profession. So as of today, we have also problems. We are trying to educate more and more and more. That's exactly the problem. But again, that's it. Yeah.
Just a comment. I think that most of the problem is in our head. I work in an underdeveloped country in France, where we have 1 to 3 nurse to patient ratio, and we are still open 24 hours 7 for patient families.
It's very different from country to country and from ICU to ICU, so I think it's good to investigate on this, I think.
Okay.
Thanks so much, Jozef.